bit of the uterine lining. Um, and so we can talk about the placebo tablets later. But this essentially is what happens during a normal cycle on a pill. Okay, and of course that's just reiterated here so that you can see the whole thing. Excuse me, I'm sorry. I'm getting sick. This is hard to record. So just a brief note on estrogens. These are, the natural estrogens, like estradiol, also known as estradiol 17 beta E2. It's a major secretion product of the ovary. Okay, there are estrogens in other places like the liver, which are shown there. There are synthetic estrogens. These are drugs that are made for enhanced oral delivery. Some of these synthetic estrogens can be topically absorbed, for different reasons. Phytoestrogens are plant-based, most often soy, and the typical dose range is in micrograms. We're looking at very small amounts of estrogen in the system, anywhere from 20 to 50 micrograms, so not very much, very, very small amounts. And of course, remember that these estrogens are made in the ovary. Here's kind of a review in terms of folliculogenesis. Realize that you've got kind of your granulosa cells surrounding the oocyte, and then surrounding those granulosa cells are a layer of thecal cells. And then, of course, as folliculogenesis occurs, we go through all these different phases of growth. And if the, excuse me, sorry. By the end of this corpus luteal phase, you basically have ovulation. And so the site of activity is really kind of these thecal and granulosa cells, which are responsible for essentially converting cholesterol into some of these androgens. And then really it's the granulosa cells that take that last step of androgens and convert it into estradiol. Okay. And so this is the anatomic site at the cell-based level as to where estrogen is made. So from a pharmacokinetic standpoint, estradiol, excuse me, estradiol in the plasma has a strong affinity to the alpha-2 globulin, also known as A2M, and also the sex-binding globulin, which is SHBG. And these are used for basically transporting this molecule through the blood. So they'll dissociate from kind of this carrier protein complex that's formed up here and bind to one of the two estrogen receptors, ER alpha and ER beta. Okay. ER alpha, typically you see it on the endometrium as well as within the ovarian stroma itself. There are some receptors within the hypothalamus. ER beta, you typically see on the ovarian granulosa cells, as well as other anatomic sites which are listed there. Okay. And so remember, estrogen binds to its receptor. The receptor moves the product essentially across this plasma membrane and into the nuclear membrane. And here you basically get a alteration in transcription, and the estrogen will basically activate these estrogen response elements on the DNA, and you get a activation of transcription. And so then this produces more protein, which has physiologic effects. And so these new protein products can be formed plasminogen, the clotting factors, et cetera. There's tons of different proteins and enzymes that are upregulated and produced in response to E2 hitting the estrogen receptor. Excuse me. And so there's these physiologic effects include obviously protein production. They're responsible for female maturation, puberty. Endometrial effects include of both muscle and lining production, numerous metabolic and cardiovascular effects, blood coagulation effects. Estrogen has the ability to induce the synthesis of progesterone receptors, which makes sense because we'll be using progesterone shortly. And they also alter libido in women as well as muscle function. So estrogen, tons of physiologic effects. And of course, this comes with risks. And so in terms of oral contraceptive, hormonal-based therapy with estrogen-only regimens, there are going to be some side effects. And so, recall that recall that patients that have estrogen positive cancers, you would definitely have to avoid these drugs. Patients with a history of migraine, it's well known that estrogen makes migraines worse. Patients with undiagnosed genital bleeding should not get estrogen therapy. Patients with liver disease, heavy smokers, and those with a history of hypercoagulated states, including a history of deep vein thrombosis or pulmonary embolisms. All these patients should really not get estrogen-only regimens because the risk of further damage and exacerbation of disease is just simply too great for these patients to chance it. And so then we kind of shifted over and decided, well, let's look at progestins. And so these were first isolated in the 1930s, and they were chemically synthesized in the laboratory in 34. And of course, these work on progesterone receptors. And it's actually called the pregnancy hormone because progesterone actually prepares and maintains the body for pregnancy. Some of these can be estrogenic or anti-estrogenic, depending on the tissue. And a lot of progesterones are actually very chemically similar to testosterone. Sometimes they're called androgenic progestins. But unlike estrogen, they have relatively a little to minor effect on protein metabolism. They do act through progesterone response elements, so mechanistically they're very similar, but there's not a huge, large-scale effect on metabolism. They tend to favor fat deposition. They tend to alter insulin levels, as well as alter sodium reabsorption at the kidney level. And so there are CNS effects. Women that are pregnant sometimes complain of pregnancy brain, and many of it is attributed to progestin's central effect. Funny story, my wife, I think when she was pregnant with our second child, had taken the car to the mall and called me, and she couldn't find the car, and it's because she was looking for the car and not the van. And I told her, I said, well, honey, you don't have the car, you have the van, so look for a silver van. And then she found it. So we were attributing that to pregnancy brain, and it's a real thing. We've experienced it. And the dose range, a little bit higher. We were talking about micrograms for estrogens. Here we're looking at milligrams for progestins. Okay, not very many milligrams, but at the milligram concentration. These can be rapidly absorbed if you give them orally, so that's good. The half-life is about 5 minutes. Okay, but excuse me. Small amounts of this drug definitely go into the fat, and there's complete metabolism and kind of a one-pass effect through the liver. So these are great for oral formulation. So